As you said, my name is Michael Harling. I'm a U.S. trained general surgeon. Completed my training back in 2017. Moved to Burundi in 2020. Um, and I definitely do not have any disclosures. Um, I think it's helpful for understanding what I'm doing here to have a little bit of context for the country of Burundi. Burundi currently sits with the lowest GDP, nominal GDP per capita in the world, has one of the highest rates of hunger, malnourishment, has a stunting rate that sits above 57% across the entire population, and under five mortality that is around 50.5 per thousand. There are only three medical schools for this country: the University of Burundi, Ngozi University, and Hope Africa University. To give a little idea about the population, we're roughly two-thirds the size of Switzerland, with current population in Switzerland being 8.9 million and the current in Burundi sitting at 14 million, and showing no signs of slowing down. At the same time, if you look at the WHO data, number of medical doctors per 10,000 population, you see Burundi sitting down there, and it's less than one medical doctor per 10,000 population, and it's been hard to gain traction as the population here has continued to grow so rapidly. It was in this context that the team I'm a part of with this organization called Surge partnered with one of the universities here, Hope Africa University, and their main teaching hospital to try to work towards improving the medical education and the throughput for the medical students. The university itself started in 2000, the medical school in 2006, with their first medical graduates happening in 2013. And as of 2023, we've had a total of 311 doctors graduate through our program. One of those is this gentleman next to me, Dr. Alliance Nyunkuri. He's actually my next door neighbor and was in that first class of graduates from the medical school. He had gone on already to do his general surgery training in Gabon, and ultimately did a pediatric surgical fellowship in Malawi before returning here. And we work alongside each other at this hospital, Kibuye Hope Hospital, which is, and as you can see, a fairly rural portion of this country that has a very high population density, the second highest in all of Africa, right behind Rwanda. It is a 320-bed hospital. We see 30,000 some consultations a year, do roughly 3,000 operations a year, and have seen huge amounts of growth since our team first arrived in 2014 now to today. Along with some of that growth, it's not just a paucity of medical doctors, it's also an extreme paucity of specialists. So we have started a surgical residency, a surgical training program as of September of 2022. We have now welcomed our third class and are up to a total of 7 residents. These two are our two newest residents, Dr. Layla and Dr. Feen, who have just started their training. The challenge is we see a great deal of pathology, and as general surgeons, we do true general surgery, everything from orthopedics, calcified retained bullets in knee joints, to mangled extremities, to plastic surgery for repairing syndactyly, to neurosurgery for myelomeningocele, to good old general surgery and pediatric surgery for removing Wilms tumors. But when you talk to our residents, you find out that they're pretty limited in the resources that were available to them for training or for learning anatomy. None of them did anything with a cadaver, prosection, or dissection. And only one of the 6 residents who responded actually had a personal textbook to use to study anatomy. The majority of them were doing all of their anatomy study with textbooks that were available at the library, and black and white course syllabi that have been photocopied for them. The one person who responded about using virtual reality anatomy software, was referring to a specific event where we actually had a Fulbright scholar who was visiting us from Rwanda to do a course on pediatric cardiac defects, and brought his virtual reality headset to show the Stanford heart model to teach the cardiology defects, which actually sparked some interest for me. We find that we are definitely not the only country that has challenges in regards to anatomic education and anatomic training for medical students. 5 out of the 13 respondents in this study had 0 hours of dedicated cadaver dissection time. And we find that even in places where cadavers are available and cadaveric dissection for anatomical education is feasible within the continent of Africa, a majority of these bodies are unclaimed, so that they have sometimes questionable provenance, and a vast majority are male, limiting some of the educational value and the ability to give the students a full and complete understanding of the anatomy that they're going to encounter as physicians and, in my case, as surgeons. And beyond that, there are a whole host of factors, cultural beliefs, religious beliefs, that contribute to an unwillingness to donate bodies. So it doesn't seem as though the problem is going to be getting better anytime soon. This study from Uganda was just published, and you can see that the majority of the faculty have no interest in having their own bodies being dissected and used for anatomic education. To that point, here in Burundi, it was actually illegal to do cadaveric dissection for any reason up until less than a year ago. So as of the 17th of April, 2024, it is finally legal to do anything with a cadaver for educational purposes. No university has made any progress in making cadaveric dissection as a part of anatomic education in that domain. So it's still a long way off, and there are still all of those cultural underlying factors that I think are going to prevent that being widely adopted for medical education in this context. So what am I to do when my residents learned their anatomy from a poorly photocopied black and white slide, and they're faced with this patient with a pretty incredibly massive goiter? How do I help them to better understand anatomy at a base level so that they can be better prepared to safely offer operations for patients like this? And it was through that Fulbright scholar who showed me his VR headset that I was struck by the idea of how useful a tool that could be. And it was a question of what their options, what is the best option, and what's going to be the most useful in our context, and the most available and most impactful for our residents, and ultimately, hopefully, for our medical students. And for me, it was Dissection Master. So I really appreciated the presentation that was just given about the progress that's being made in Dissection Master. The first time I put on the headset and experienced Medicalholodeck and experienced Dissection Master, I had olfactory hallucinations, and my brain was telling me that I was smelling formaldehyde from my own personal experiences doing cadaveric dissection during my training. And that really captivated me and helped me to realize that this is different and this is special. None of the other programs out there have anything remotely like this. And when it comes to teaching basic anatomical concepts to medical students, this far and away sets Medicalholodeck apart from anything else that's available. The other thing that was really important to me is the record function that is available within Medicalholodeck. I am one surgeon who also wears the hat of IT professional and biomedical technician and surgical educator and about 15,000 other different things. So it's impossible for me to continually teach the same things to each subsequent generation. But if I can record in spatial reality that these educational lectures that students can come back to and that can be used for each subsequent generation, that really does a lot to take an educational burden and time burden off of my hands, and allows me to ensure that the education that our students are receiving is truly top notch. So that's exactly what we've done. As kind of a pilot study, I've started using Medicalholodeck with our surgical residents. Their need is the most pressing. They are already in the process of learning how to operate and have pretty significant gaps in their anatomic knowledge because a majority of it was learned from black and white paper images. So we have started to incorporate medical holodeck into our coursework. So as we go through a segment of our lecture series on gastric anatomy, on gastric tumors, we'll go back and we'll look at blood supply to the stomach, its relation to all of its surrounding anatomic structures. And I think it has really helped our residents to have a better understanding of where anatomic structures sit in 3 dimensions. And we have used it through, I've used it through with all sorts of residents, some who have been with us, some who are visiting. This is a visiting resident from Cameroon. This is a Burundian resident, but he's actually doing his training or has finished his training now in Kenya. And he had gone through the medical system here in Burundi. And his first words when he put on the headset were, "Wow, I really wish I had had this when I was doing my med school." Because it struck him as he was towards the end of his training to become a surgeon, how much he had struggled in really understanding the spatial relationships between anatomic structures because of his background and educational history. And at the same time, it's not just for our surgical residents. This is a cohort of nurse anesthetist students who had come through, many of whom who hadn't really received nearly adequate or very good education about upper airway anatomy. So I was doing a quick tutorial on upper airway anatomy and combining that with using some of the mannequins that we have available to help them better understand what good and safe intubation looks like. So I've really tried to incorporate virtual reality education kind of across the board, predominantly for our surgical residents, but also for the nurse anesthetist students and the nurse anesthetist faculty who are with us to do some continuing medical education to improve their anatomic understanding and their ability to practice safe medicine in what is often in a extremely difficult context. So where do we go from here? Currently have 3 headsets purchased with personal money. And I would really like to get up to a total of 15 headsets, in part for our surgical residency so that we can have all the residents in virtual reality at the same time as we are doing some of our tutorials. But then beyond that, I want to make these headsets available to our surgical residents regularly so that we can record lectures that cover some of the most frequent and challenging anatomic concepts that we encounter so that they can be better prepared to take care of their patients. I am glad to see some radiologists here. I had the benefit of having the learning in the kind of the opposite direction where I did my cadaver dissection, I learned anatomy, and then during residency, I saw CT scan after CT scan after CT scan where it was all interpreting those 2-dimensional images. But I want to flip the script for our residents. Most of our patients can't afford CT or MRI. It is there's limited availability. The closest is about 2 hours away from our hospital. But I think the technology is coming to our country, and I want to prepare them for that day when more residents will have CT scans. And I really think that loading the images in 3 dimensions and getting a better spatial understanding helps in interpreting the 2D plane images as well. Even with the possibility that sometime in the future, they can skip the step that I went through and not actually look at their CTs in 2 dimensions and just go straight to looking at them in 3 dimensions, and how much of a benefit that would be to them in their surgical planning. I'm also interested in looking at some techniques and figuring out some techniques to measure my residents' spatial reasoning and see if there's a way to actually demonstrate the effectiveness of this educational tool in their education. With those extra headsets, I'm hoping to implement a full virtual reality, augmented reality course at Hope Africa University with recorded coursework in French. And then I have some ideas for a study that I would like to do, splitting the class into 2 cohorts with crossover to actually measure how well it influences their ability to learn anatomical concepts. A lot of the studies that I've seen and a lot of the reviews that I've seen, there's a lot about the med students' perceptions, but there isn't a lot that actually measures for real difference in comprehension of the of the subject material. And I think there's great opportunity here to demonstrate just how effective VR and AR are for teaching anatomy. Part of that is, I think, slightly selfish reasons, because I would really like for the whole East Africa community, which has site visits to validate medical schools, to really accept that VR AR is a viable alternative and a very cost-effective alternative to cadaver dissection. And really opens up, I think, huge opportunities for vastly improving the anatomy education in this sub-Saharan context. There are, of course, many hurdles. We are extremely resource constrained, and there are not funds currently available to buy those 12 extra VR headsets. None of the anatomy professors at the university have any experience, so there will be some time that will be needed to educate them on its utilization, as well as fairly limited IT support at the university. Internet is a big deal. Fixed line internet here in Burundi is amongst the most expensive in the world. You see that vague $305 for a broadband connection, 50 to 60 megabits. I think that's actually an underestimate. Our team used to pay for a 20 megabit internet connection that was over $1,000 a month. So getting adequate bandwidth to download the models to allow for remote and even local interaction in VR has been challenging. Starlink is now available, and I'm hopeful that that will change the internet landscape for us so that we can better utilize some of the built-in functionality. And then because CT and MR is so expensive and so infrequently used by our patient population, I don't have any de-identified imaging data for training. And I have not been able to find a good source for that. So finding DICOM images to create, even setting up my own local PAACS so that we can look at some of those images and I can use them to train our residents has been a big issue. If any of you have any suggestions or want to hear more, this is my contact information. I'll leave it up here for a second. And if there are any questions, I'd be happy to answer any of those. Thank you again for this opportunity.